everybody, and thank you for joining me in this new short video presentation from ARIA EpiTalk series. Today we will discuss together the ECG findings and also high resolution mapping of the right and left atrium in a patient who received inappropriate ICD shocks due to a supraventricular tachycardia. I hope you will enjoy this video and join me here in my future video presentations. If you are new to my channel, please do not forget to subscribe. Now let's look together at the first patient, 67-year-old man suffering from recurrent palpitation who was admitted to the hospital for RF ablation. Here we see the 12-lead ECG, which is compatible with the diagnosis of typical atrial flutter, isthmus-dependent, counterclockwise, macro-reentrant right atrial tachycardia. The ECG is very clear. Also, the entrainment mapping before catheter ablation confirmed the diagnosis. But now let's look together at high-resolution mapping performed during mapping in this patient. So here we see on the right side propagation mapping, and on the left side we see the sparkle mapping. Both methods actually shows the nature of the tachycardia, a macro-reentrant atrial tachycardia around the tricuspid valve. When we look through the tricuspid valve, we can also see the line of the functional line of block at crista terminalis. In the next video, we can look closer at crista terminalis and see the functional block which actually help to sustain this tachycardia circuit. Here, as I said, we see in the posterior anterior view, again on the right side propagation mapping, and on the left side the sparkle mapping showing the line of block along the crista terminalis. And here we can see the crista terminalis on the right side. This is the location, and we can see the line of functional block, which, as I said, help to sustain the circuit of this kind of tachycardia. The more interesting patient is the second patient, which is a 41-year-old man with aborted sudden cardiac death in 2000. The diagnosis at that time was non-obstructive hypertrophic cardiomyopathy. ICD was implanted in 2013. The patient received a biological tricuspid valve implantation. The admission was due to inappropriate ICD therapies because of atrial arrhythmia, and then it was referred to our center for catheter ablation. This is a video from year 2017. After the first operation, the patient experienced a severe tricuspid regurgitation, and 2017 the patient received interventionally an Edwards Sapien 3 valve 29 millimeter in tricuspid valve position, and in this way, so the tricuspid valve regurgitation was cured. Let's have a look at 12-lead ECG. The 12-lead ECG in the first glance looks completely like typical atrial flutter, especially in the inferior lead and in the precordial lead. If we look closer at precordial lead and the inferior lead, this is typically like a typical atrial flutter. On the right side, we see the typical pattern of P-wave morphology break, starting in V1, V2, a positive wave, and then isoelectric, and finally we see a negative P-wave or flutter wave in V4, V5, V6, which suggests an right atrial origin. So the ECG is exactly looks like the first patient and looks like a typical atrial flutter. After placing the catheter, the entrainment mapping, however, was not compatible with the diagnosis. And now we see the high resolution mapping of right atrium during tachycardia. And now during high resolution mapping, here we see the propagation mapping, and this map also confirms the finding of entrainment mapping that this tachycardia is not macro-reentrant right atrial tachycardia. However, when we look at both cases, this one and the previous one, the septal activation looks similar in both patients, and this is very important and shows that the importance of septal activation in generation of P wave and also flutter wave morphology. And despite completely different mechanism, we see the similar P wave morphology in both patients. And the reason is similar septal activation, which in the first case was due to atrial flutter, right atrial flutter, and in this case was due to left atrial flutter with left to right conduction through CS ostium, which then generates a propagation mapping on septum and superior septum similar to a patient with right atrial flutter. Now we go to the next map, which shows the high resolution mapping on the right side, the substrate mapping, which showed the scar area on the posterior wall close to the right superior. On the left side, we see the propagation mapping and also the coherent mapping, which shows a micro reentrant atrial tachycardia at the location of the scar. Here we can see the recorded potentials on lasso catheter located on the circuit of micro reentrant tachycardia, and we can see especially on lasso 5-6 the continuous electrical activity, which is a hallmark of micro reentrant tachycardia in this patient, and confirms the diagnosis because we see that in a small area we have more than 75% of the tachycardia cycle length, and this continuous electrical activity here also confirms the diagnosis of micro reentrant atrial tachycardia. To put together these two patients, we had two patients, one with right atrial flutter, typical right atrial flutter, and another one with micro reentrant left atrial flutter, but with similar ECG findings. And the reason for the similar ECG finding was similar pattern of septal activation. And now we saw together the importance of septal activation in generation of the P wave morphology on surface ECG. At the end, I hope you enjoyed this presentation, and I would like to invite you joining me here in my future presentations. Thank you.